In this video, we describe how to dissect the mediastinum. This work was created by Dr. Carlos Andres Suarez-Quian and Dr. Joel Walensky. Dr. Suarez-Quian is the narrator of this video. The mediastinum refers to the midline of the thoracic cavity that is surrounded by the left and right pleural sacs. It is divided into the superior and inferior mediastinum by the sternal angle, or angle of Louis, an imaginary plane that extends approximately from the inferior border of the manubrium anteriorly to the T4-T5 intervertebral disc posteriorly. Let's start the dissection of the mediastinum. As we demonstrated previously when we took out the lung and the heart during the first dissection in this series, access to the mediastinum is gained by raising the anterior thoracic wall, as shown in this image. We now see the mediastinum clearly, the center portion of the thoracic cavity, and we previously discussed that the principal component that was of interest to us was the heart. Indeed, we demonstrated how to remove it. However, that was in the inferior part of the mediastinum. What do we find in the superior mediastinum? The area posterior to the manubrium, the area on which we now focus our attention. Please be aware that because many of the vessels and nerves in this region can be small and difficult to visualize in a video, that in this video we opted to colorize many of the vessels and nerves. Although in the cadaver it appears to be nothing more than a fatty area, in reality, think of this as the first plane of the superior mediastinum that is represented by glandular tissue. The gland that is demonstrated here is what's left of the thymus. In the adult, the thymus consists of two lobes and is mainly fat, but small islet areas of active thymic cells will be scattered throughout the tissue. If we tease apart the fat carefully and discard it, eventually we make it to the next plane, the venous plane, now demonstrated in the field. As in previous videos, we have removed the pericardium from the heart so that the heart is now exposed. Having completely removed the clavicle, we can see the origins of the left and right brachiocephalic veins that form from the joining of the internal jugular and subclavian veins. Realize, however, that for the present discussion, only the brachiocephalic veins interest us because they are the ones found in the mediastinum. The subclavian and internal jugular are denizens of the neck and upper limb. The brachiocephalic veins come together to give rise to the superior vena cava, now labeled. But missing from this field of view is another important vein of this region, the arch of the esophagus. To observe the arch of the esophagus, we need to rotate the mediastinum and look at it from the right side, as is shown in the next image. Here, we can see the arch of the esophagus as a continuation of the esophagus vein. The arch joins the superior vena cava. Just inferior to the arch is the right primary bronchus, which has split from the trachea. We can also see other structures, but we'll describe these as we continue to define the various planes of structures that make up the superior mediastinum. We now move to the third plane of the superior mediastinum. Here, we will observe major arteries leaving the heart and nerves traversing the region. First, to the arteries, we encounter the ascending aorta and the aortic arch. There is a cleft in the aortic arch, but this is an artifact of the embalming and blood not being present in part of the arch. The cleft formed when the aortic artery wall collapsed during the embalming. The three major branches emerging from the aortic arch are also evident. They are the brachiocephalic artery, the left common carotid artery, and the left subclavian artery. On rare occasions, you may also encounter another branch of the arch, the left vertebral artery, which is usually the first branch from the left subclavian artery. We also cannot forget the pulmonary trunk, or artery. Remember, this is the one major artery that carries deoxygenated blood from the heart to the lungs. The definition of arteries is that they carry blood away from the heart, not that they carry oxygenated blood. Most arteries do carry oxygenated blood, and the walls are thicker to withstand the higher pressure to which they are subjected to, vis-a-vis the veins, but this has nothing to do with the definition of the term. We now turn to the nerves, and here we see the two major sets of nerves we observed previously when we were removing the heart and lungs from the thoracic cavity. Anterior to the root of the lungs, we found the phrenic nerves. The nerves are accompanied by the pericardiophrenic artery and vein. Posterior to the root of the lung, the vagus nerve is evident. Here, we can only see the left vagus nerve. Separating the pulmonary trunk from the arch of the aorta reveals a short ligamentous structure, the ligamentum arteriosum. This ligament represents a remnant of the ductus arteriosum, which in the fetal circulation shunted oxygenated blood from the pulmonary trunk to the aortic arch. Remember, in the fetal circulation, oxygenated blood is brought to the heart from the maternal circulation via the venous system. Thus, oxygenated blood will leave the right ventricle as opposed to adult circulation, in which the pulmonary trunk sends deoxygenated blood to the lungs. Also, running just posterior to the ligament is the left recurrent laryngeal nerve. The vagus will then continue towards the esophagus to form the esophageal plexus, although this component of the left vagus is hidden in this image. As an aside, the right recurrent laryngeal nerve is not found in the superior mediastinum. It remains in the root of the neck, as shown on the image. Review your embryology as to why this is so, and also why this knowledge is of clinical relevance. The location of the left recurrent laryngeal nerve in the superior mediastinum makes it susceptible to a pancreas tumor spreading to this area from the apices of the lungs. Symptoms will include hoarseness due to a compromise of the nerve, which innervates muscles that control the vocal cords. This image also demonstrates a fourth plane of structures in the superior mediastinum, which is represented by the viscera. In this plane, we find the trachea and the tracheobronchial lymph nodes. Anatomically speaking, the primary bronchi are not in the mediastinum. Finally, in this image, note the left recurrent laryngeal nerve again, just to the left of the trachea, on its way to the larynx. The next step in the dissection is to reflect the aorta out of the way and slice open the trachea, but keep its posterior border intact. I have now labeled the structures for orientation. The prominent ridge at the back of the trachea is called the carina. The carina is also partially responsible for why aspirated objects tend to enter principally the right primary bronchus. Recall also that the right primary bronchus is wider and straighter than the left. The third component found in this plane is the esophagus, which is just visible in the image. I will show another image of the esophagus momentarily. Here's another image of the esophagus, which is now more exposed. The trachea and right primary bronchus have been displaced to the left to grant a better view of the esophagus. The nerves sitting on the esophagus represent the esophageal plexus, formed from branches of the right and left vagus nerves. In general, because the esophagus rotates to the right during development, the fibers on the anterior surface of the esophagus will have emerged mainly from the left vagus. The posterior fibers will have emerged from the right vagus. Understand, however, that the esophagus is a truly extensive muscular tube that spans from the termination of the pharynx to the diaphragm. Students often underestimate the muscular nature of this organ as well as its continuation. The next step in the dissection is to separate the posterior parietal pleura from the thoracic wall. Although there is endothoracic fascia outside of the parietal pleura, the membrane we see is truly the parietal pleura that was left behind when the lungs were removed. Labeled in the image is the right sympathetic trunk, which can be discerned deep to the parietal pleura. The parietal pleura is removed by grabbing the cut edges and peeling it off the thoracic wall. This now reveals the principal structure found in the last plane of the mediastinum, the thoracic duct. Because the thoracic duct is such a delicate structure, difficult to see even in real life, I now show the same image, but with the duct colorized in green. Careful dissection of the thoracic duct reveals that it extends from the aortic hiatus all the way to the superior mediastinum, where it crosses over from the right side to the left side of the superior mediastinum at the approximate level of the sternal angle. Indeed, this is a classic gross anatomy question from years back. Which duct crosses at the angle of Louis? The thoracic duct will ultimately exit the thorax and will drain at the juncture of the internal jugular vein and the left subclavian vein, as indicated in the image. And if you truly understand the extent of the parietal pleura, technically, one does not need to remove the parietal pleura to demonstrate the thoracic duct. Removal of the parietal pleura, however, is necessary to demonstrate the sympathetic trunk and the greater splanchnic nerves as shown in the image. Although, to be anatomically precise, the sympathetic trunk is not necessarily found in the mediastinum, it is adjacent to it. Nevertheless, exposure of the sympathetic trunk is commonly done at this step, as I have done here. The relationship of the intercostal vein, artery, and nerve, or VAN, is also possible to more clearly discern after removing the parietal pleura. Here we see, from above downwards, the intercostal vein, artery, and nerve. Note their close proximity to the underside of the rib. It is for this reason that needles and chest tubes into the chest are introduced above the superior margins of the ribs, not below, so as not to injure the intercostal nerves. Finally, you can also discern in this particular dissection a gray and white ramus of a spinal nerve. This now concludes the dissection of the mediastinum.